And so I was asked to speak about the new anesthesia medications for adults. And I took this to be over the past few years. And so I'll review these past few years and give you some insights into what's going on and why it might be important for the treatment of epilepsy. I have some disclosures. I've consulted for several of the companies whose products are going to be discussed today, and consult in the way that I'd share my understanding with them as I'm sharing it with you today. And I'm going to start with cannabidiol, which was a very hot topic a few years ago and continues to be a very important topic. I think some of the hoopla has died down as people no longer see it as being a forbidden fruit, but see it maybe as a meaningful medication. And I thought I'd give some perspective on this because I think even with this greater understanding, there's still a fair amount of misinformation and gaps in understanding overall. And so I was starting with cannabis. Cannabis is a plant, and the cannabis has 2 or maybe 3 individual types, the sativa, the indica, and then maybe this other one, ruderalis. And the plant has been recognized and cultivated for thousands of years and recognized to be useful for its fibers, as well as the seeds. And the use has gone back, well, now almost 5,000 years. A Chinese medicinal compendium from 2737 BC describes the cannabis plant as being useful for memory and mood, treatment for stroke. And stroke was recognized, of course, then it's obviously the case, and inflammatory conditions and constipation. So it was a medicine back then. It then became much more widely used as an intoxicant, and that's where, of course, most of us first heard of it, through recreational marijuana. But cannabis would be the more proper term for it. However, the use for treatment for epilepsy on record goes to at least 1850. The US Pharmacopoeia was the official Bible of sorts for the treatment of all medical conditions in the US. This is before the FDA existed. And it started in this time as a list for doctors and pharmacists to have a full compendium of all the treatments. And within the US Pharmacopoeia from 1850 is cannabis. And the list of things that can be treated include, you'll see here, convulsive disorders. So in a sense, cannabis has been on label for epilepsy for 170 years, and just dropped off the label for, of course, much of that time. So there's nothing really revolutionary about the idea that this might be helpful. The question is why and how do you control appropriate use of it? This brings us maybe into a little backdrop to a few years ago, and Charlotte Fagey, who was a young girl with Dravet syndrome, who was interviewed by Sanjay Gupta, you see in the lower picture on CNN. And Charlotte's epilepsy was very poorly controlled, and she was treated with a enriched cannabis, or that is a cannabis that with enriched CBD within it. And CBD, as I'll mention, is one constituent compound within cannabis, and her seizures responded amazingly well, which is a fantastic thing. And it became a point of interest. Ultimately, though, as a physician, I love the idea of the Charlotte responding well, but what I really need to know is how many people respond well and what type of seizures do they respond well to with this. And so that became a point for further investigation. The twist is that Charlotte really was not the beginning of CBD for epilepsy as a medicinal purposes. This young man, Sam Fogelstein, who also had poorly controlled seizures, he does not have Dravet syndrome. My reading doesn't clarify what type of epilepsy he has, but his parents brought him to England, where he was started on an enriched CBD preparation and responded well to it. And this was in a controlled setting. I'm just receiving a message, internet connection's unstable. So Adriana, if there's a problem how I sound or such, please let me know and we'll make adjustments. I got a computer warning just now, so excuse me if there's a problem going forward. But Sam responded very well, became really the key patient that led to the development of CBD for epilepsy. So what do you mean by CBD? And this is going to be a dizzying slide for many of you because these are molecular structures. And the important point of the slide is on the left side shows compounds that are in cannabis. Cannabis is a plant. Plants, like everything in the world, is made up of different chemicals or compounds. And within cannabis, there are about 105 what are called phytocannabinoids, meaning plant-based products that have a similar molecular structure. THC is one of these phytocannabinoids, and it's the compound in cannabis that produces the high, as many of you already know. CBD is another phytocannabinoid, and it's also in high concentration in cannabis and Different strains of cannabis may have different proportions of THC and CBD. But there are about another 100 phytocannabinoids. And most of these aren't not really well understood in terms of their medicinal potential or what they do in general to the body. And this is all part of what's taken in with the use of medical marijuana or medicinal cannabis. But our investigations, our meaning scientific investigations, not mine personally, were toward the compound that seemed to be most promising, and that was CBD. The twist of this, and this is something that I think gets missed by many people, is that we end up understanding the body or the brain specifically by looking to find compounds that affect the organ, the brain, and then figuring out what these compounds are doing, and then finding compounds within the brain that have similarity. It's almost a reverse engineering. This is how we have pain medications. Opium is comes from poppies and flowers, and for millennia, people recognize the pain reduction from opiates, from these flowers, and by recognizing the compounds within it, an entire system of chemicals in the brain were identified. And the same is happening with the cannabinoids. And there's now recognized to be a system in the brain, what are called the endocannabinoids, that have roles in brain function. And so what's happening is some of the some of the molecules in cannabis mimic the molecules in the brain to produce effect. And that's essentially how all neurologic drugs work, as well as other drugs outside the body. It's mimicking systems or affecting systems based upon binding molecularly based upon similarity. And so I'm not gonna get more into that, but to show that this is not magic. This is something that can be understood and studied, and that's going on right now. So cannabidiol in the United States is approved by the FDA for the treatment of epilepsy. It has no other official approval. And so the only FDA-approved version of cannabis is cannabidiol, and the only FDA-approved use of it is for epilepsy. And the approval is for seizures associated with Lennox-Gastaut Syndrome, Dravet syndrome, and Tuberous sclerosis complex. I'll be describing what these are to bring everyone up to speed in a moment. And at age 1 and older. And you see the italics these because these were changes to the official label or the official approval just recently. Originally, it was only for the first 2 conditions, and it was at an older childhood age. But as I said, it's not magic. And the question is, what is cannabidiol doing? It is a medication. It is a drug in a sense, in the same sense as a medication. All medications are drugs. And it's binding to proteins in the brain and affecting a change. And there are multiple mechanisms that are thought to be present. But what's really interesting is the difference between cannabidiol and THC, in that they both have an effect on a certain protein in the brain called CB1. They have opposite effects, but that CB1, this protein, is highly abundant throughout the brain. I mean, the endocannabinoid system, in other words, is an important system of regulation within the brain. And it's a system that we're only beginning to understand. And so the exciting future is, as this gets taken apart and understood, by taken apart I mean understood intellectually, we may have other opportunities to produce treatments for other conditions, even outside of epilepsy. And the mechanisms that cannabidiol has on the brain differ from other anti-seizure medications. So we are expanding our opportunity using this molecule. So I wanted to give a backdrop because I think the audience has heard these terms before and maybe needs some clarification for at least some people. And the first is Dravet syndrome, which is what Charlotte Fahey had. And if you don't know, Charlotte Fahey passed away this spring. So it's a question of the past. Dravet syndrome develops in infancy and often first occurs with seizures that may be associated with fevers, which is the term febrile. And these seizures might be full body convulsions, what are called generalized, or they might be half the body and have more jerks, which is what hemiclonic is. It may produce seizures that are prolonged, which is status epilepticus. And other seizure types may occur during childhood, including seizures of staring off, or seizures which are absence, or seizures with jerks that are called myoclonic. And I want to clarify these terms for you. I'm sorry, I'm advanced a slide by mistake here. But you recognize some of these slides I use when speaking to physicians, so it's the same level of detail. EEGs are helpful for Dravet syndrome. There's certain features on EEG that support Dravet syndrome, but there's no feature that says this is definitely Dravet. And the MRI of the brain is often normal, doesn't show a clear abnormality. Dravet syndrome is typically genetic, and there are 2 genes, and one in particular, SCN1A, where it's causative, where a mutation of that gene causes Dravet syndrome. And so with Dravet often comes some intellectual disability, sometimes interpersonal interactions abnormality, and it can be difficult to treat with full seizure control, which is the need, and that's where Charlotte's parents sought out other possible treatments, which led to cannabidiol. One important last point about Dravet syndrome is the recognition now, which wasn't the recognition earlier in my career, that the anti-seizure medications, ASMs, that have a mechanism through what is called the sodium channel, this is an ion channel on neurons or brain cells, that these medications can actually make the seizures worse. And so it goes to the point that choosing an anti-seizure medication for a patient has to include some understanding of the diagnosis and thought about what is the best medication, and also considering that sometimes some medications actually can make things worse. And this is an example of that. Lennox-Gastaut syndrome is less precise. It's less one thing than Dravet syndrome. It's really a collection of many different conditions that we can't really separate clearly that have certain things in common. And it's also a childhood onset of epilepsy, and it also includes multiple seizure types, sometimes staring spells, which are the absence, sometimes full body convulsions, which are generalized tonic-clonic, that's GTC, but also other seizures that may cause drops or falls. The EEG has a certain pattern that's typical of it, that may be different in adulthood, and the MRI can be many different things. There's no MRI signature for Lennox-Gastaut syndrome. There are many different causes, and one common cause is tuberous sclerosis, that I abbreviated here as TS, which we're going to get to in a moment. But it could be a cause that's not visible on the MRI. It doesn't have to be genetic. What makes it one thing or one syndrome is the combination of the seizure types, the EEG pattern, and intellectual disability, which goes along with it to some extent. And we tend to think about choosing medications that have benefit for generalized seizures, seizures that start very broadly and diffusely. And then the last part in terms of the epilepsy education is tuberous sclerosis complex, which is now on label for cannabidiol. And this is not one condition, well, it is one condition, but it's not one epilepsy.
Dr.
And
Stern,
it
we
really
do
is not
have
even
one
epilepsy.
question, if I may ask a
Please.
question. Okay. Does
Please
CBD
do.
work for Javon syndrome?
Javon syndrome. You know, I'm not aware of a study looking at that specifically. I could have missed something. However, based upon its benefit for other types of epilepsy, I would expect some benefit. In reality, and this is not just true for CBD, but for many of the medications, the benefits for different seizures go beyond what was studied in the initial clinical trials. And identifying that those situations happens slowly, meaning over years, as different patients try it because of need for it. And so I would expect some benefit in that, but that's not based upon any personal clinical experience or any trial data. Hopefully that gives a fair but honest answer. For tuberous sclerosis complex, it's a genetic condition. There are two genes that cause it, TSC1 and 2. And the genes cause malformations or structural changes in many different organs in the body, the brain included, but also the kidneys, heart, lungs, eyes, and skin. And it's the changes in the brain that can cause seizures in some people who have tuberous sclerosis. Not everyone with TS has seizures. Not everyone has evidence even on the brain of abnormality. It's not universal is my point. And these malformations, these changes become irritating to cause seizures. But even then, it can be seizures that develop in infancy or seizures that first develop in childhood, or even sometimes later than that. And so ultimately, it's really quite diverse. And so I think an interesting twist to the updated cannabidiol label is the seizures of tuberous sclerosis, because that's not one seizure type, that's one cause. And it's an interesting thing for me as a researcher in epilepsy to think about the decision-making that led to thinking about studying it that way, but also the benefit we got from that with FDA giving the blessing for seizures of many different types from one medication. So I'm thinking about time, and I'm gonna just point out that there were several very rigorous controlled studies of CBD for epilepsy, which is what led to the FDA's approval. And response rates were very much like other clinical trials. one unfortunate or fortunate or strange reality is that we end up seeing very similar results across this for epilepsy. That the response rates for a medication that's being tested in a trial compared to placebo are very much similar to one another across different medications in different countries and different studies. And thinking about why that should be is maybe a much longer conversation. But the CBD results were very much like that. And so we have as much evidence that CBD works for epilepsy as we have evidence for all the other medications working, which is the great thing. And that evidence shows very similar response rates. And so it's not a miracle drug in the way that sometimes it's been touted to be in some circles, but nor is it something that's on the fringe. I mean, it's conventional, traditional medicine at this point. And it's been studied for Lennox-Gastaut. You can see similar results. About 40% responded, compared to about 20 on placebo. I'll go back a slide just to point that out. Here was almost 40 to 39 compared to 13 on placebo. And then another study about 40, about almost 20 on placebo. And these are just CBD, but I promise you that looking across the trials done since the 1990s, response rates are all very much similar for the most part. That's a little bit of a heads up for later on. This is the Tuberous sclerosis study. And actually looking out over 12 months, the response rates, another point to make, the response rates in the trials tend to be over 12 weeks or so. And ultimately, we want medications that control seizures for years, not 12 weeks. And so examining how well a medication works over time becomes an important part of confidence in it long term. So CBD comes from cannabis, marijuana, and there was concern about its abuse potential because marijuana is considered Schedule I by the DEA. Schedule I means no medicinal value, high abuse potential. Other Schedule I compounds or drugs are heroin, LSD. Schedule II are substances that have abuse potential but may have some value. And this includes cocaine and methamphetamine. So cannabis is considered more of a problem than methamphetamine and cocaine to the DEA. And that's, of course, a high bar to pass in order to have a medication approved. So CBD was scrutinized for abuse potential. CBD being, as I mentioned before, one of about 100 phytocannabinoids in cannabis. We know THC produces a high. And the question is, what does CBD do? And not to get into the details of the graph you see here, but compared to Xanax and synthetic THC and placebo, it didn't show much abuse potential. And so the strange circumstance was that CBD was scrutinized for abuse potential, was found to have no clear evidence of it, but when it was first approved by the FDA, it was listed as Schedule V, which means minimal abuse potential. And when that happened, I, among some of my colleagues, wondered, how did the FDA come to that decision of Schedule V? And that was quite unknown to us until CBD, meaning Epidiolex. Epidiolex is the brand name for CBD for epilepsy, just to specifically point it out, because that's what was approved by the FDA. That it was made Schedule V because of treaty obligations that the US government had with other countries. And in fact, based upon the science, it should not be scheduled at all. And it took some time for those treaty obligations to be cleared. And with those that elimination of those obligations the DEA had, then Epidiolex was eliminated. It's no longer scheduled at all, which follows the science. So I guess you can say politics steps in front of science sometimes. As any medication, there are side effects. And important side effects to recognize is that it can affect the liver. And it can cause digestive problems, including stomach upset and diarrhea, which is sometimes dependent upon dose and what else is being used. But it's not without the consequences of any other medication, which is, of course, like any medication. And there are medication interactions. And so one really important part of the evaluation of any new compound to see whether it should be made into a medication and released to the public is to understand the safety as well as how it interacts with other medications. We don't know how marijuana interacts with other medications. And part of that is because marijuana is so many different things in cannabis. But for CBD, we have very clear understanding of the interactions with many other medications. And this is part of the decision-making clinically. I'm not going to get into this, of course, but It's part of being able to use a medication safely and intelligently. And then just finishing up with CBD. Of course, CBD can be obtained from dispensaries, so depending on the state. And the question is, well, what are you getting? And the answer to that is, who knows? The studies, some of these government, FDA, and some of these academic researchers purchasing cannabis products from dispensaries show that the labels are not very accurate. And it really is, I think, I'm not going to imply any duplicity or anything. I'm just going to say it's hard to extract CBD from the plant reliably and purely, and then to measure it accurately. And this is high-level chemistry. And so what's being trusted is that the person who provides that dispensaries has those skills and has those facilities to do what would normally be done in a large industrial laboratory. Typically, the CBD concentrations were a lot less than indicated, and there was one example where there was no CBD in the product at all. Here, actually, I forgot, it was 6 conditions in 2015 where it was labeled as CBD, but there was no CBD in it. And then, actually, my last slide in CBD, because you probably had enough of this, is this entourage effect, which is discussed in medical marijuana circles. And to point out the science and what's understood and where that ends, in that these endocannabinoids, these molecules or these chemicals in the brain, they're part of the brain's natural system of regulation, have interactions with one another. And these were called the entourage congeners, meaning compounds that go along with the endocannabinoid. Anandamide, which is listed here, is something that binds to the CB1 receptor. And so having other molecules along with it changes the function. And that's something that's still being worked out on a neurophysiologic level. The relevance of this to medical marijuana is still unknown. I mean, we don't know whether you have to have a mixture of different phytocannabinoids or not to have the benefit. And so my mind is open. My mind is open for whatever evidence we have. I'm not going to jump to any conclusions. I'm just going to say that's where we are right now. So that's cannabidiol, or Epidiolex is the brand name. The next medication I'm going to talk about, which is actually only this year, is Fenfluramine. And Fenfluramine is a medication that was approved by the FDA in 1973 and then taken off of the list of approved medications in 1997. And as you see here, is back. And so this commentary, this is an article from 2018, very catchy title of Back from the Dead, was an editorial about the emerging evidence that fenfluramine may be an important medication for certain forms of epilepsy. And so a medication that was thought to be gone was being prophesized to be resurrected, which it was. And so fenfluramine was used for weight loss since the 1960s. It has an effect on systems in the brain for serotonin that decrease appetite. It was combined with another medication called phentermine in the early 90s, or maybe it was late 80s. And clinical studies at that time showed significant benefit of weight loss. You can see one trial from 1992. Subjects who weighed 200 pounds on average lost an average of 32 pounds and became very commonly used. Maybe some of you remember Fen-Phen, which was fenfluramine, phentermine. The first Fen was with an F, the second Phen was with a PH. And with the common use became wide recognition of some problems. And these problems became very serious, where some individuals developed very serious heart conditions with leaking of the valves in the heart and buildup of pressure in the lungs, requiring surgery. And so a series of papers in the 90s showed these risks, which is what led to the removal of Fen-Phen as a medication. What has been discovered since then is that phentermine may be more of the culprit than fenfluramine, because phentermine is now known to have an effect called MAO inhibition that produces a syndrome that can cause those heart conditions. So I don't know. No one knows if exactly that's the case, but we have a reason to suspect that it might have been more the phentermine than the fenfluramine. Ultimately, we never know until we know, but that's part of the backdrop. So what happened? I'm going to get past the toxicity. and say that in the 1980s, two very famous epilepsy experts, Accardi and Gastaut, both in France, had some patients who were being treated with fenfluramine and noticed seizure improvement. And in the late 80s, there was a pilot study of just 33 patients that showed benefit. And these patients were all very small groups, and it kind of trickled forward. But then with the explosion of use of Fen-Phen, it became almost a side story because it's considered of danger. By the way, of these patients who responded, many had the SCN1A mutation, we later learned, that causes Dravet syndrome, which brings us back to Dravet. So here's a curiosity. Fenfluramine was used for epilepsy, for seizure control in a group in Belgium. These children responded very well and were being followed very closely. And the question is whether they could continue being looked at, whether fenfluramine could be considered for use for epilepsy. And so what it came to is a royal decree. And so you can say that a royal house, a monarch, had something to do with the movement of fenfluramine back to use for epilepsy because of the question of humanitarian need. The children who had epilepsy who were on fenfluramine were looked at with echocardiograms, checking the heart for the heart valve problems, and they seemed not to develop it at all. So questions came up, well, it could be that they didn't have the weight problems of the people using it for weight loss. There are also children where children were not using this for weight loss in the 1990s. These were middle-aged adults. And so the question becomes, who's more vulnerable? Or maybe it's what's the real risk? Or maybe it was the other medication in it. But all these are reasonable questions to go forward and think about fenfluramine given the response rates. And so clinical trials were done that are of the same level as any other trial, but looking specifically at Dravet syndrome. And Dravet syndrome is not common. I have patients in my clinic, my practice with Dravet syndrome, but not many compared to all the other forms of epilepsy. But Dravet syndrome can be very challenging because of seizure control. And what was found is that the response rates for fenfluramine for Dravet syndrome were similar to what was seen in that small group in Belgium, that people, or children, young adults, had better response than to other medications prior. And looking at over 2 years and looking at older children and younger children, there seemed to be continued improvement. This is a paper just that was published this year looking at this. So it's all relatively new data for one little area of epilepsy, but a very challenging, very difficult area of it. And in some ways, just as an aside, I think this is maybe part of the future for the treatment of epilepsy as we start thinking about specific diagnoses of very narrow conditions, not like focal seizures, which is how many epilepsy trials are done, looking at anyone who has a seizure that's focal, but looking for specific forms and thinking about maybe there are treatments that are very specific to that form that produce a better response than the general response. Side effects, of course, we have to look at that. And there was some decreased decreased appetite and some weight loss as well, but not as much as you'd expect based upon the wide-scale use of it in the 1990s, but it's there. The other part of this, and I don't have a slide for this because it just came to mind just now, and I thought about it, is the mechanism of fenfluramine, I said earlier, was through serotonin, which maybe you've heard of, and that's a transmitter in the brain that's been studied as far as for depression and has an effect on seizure control. But the serotonin system also has been implicated as part of what goes awry with sudden unexpected death in epilepsy, or SUDEP. And so there have already been studies undertaken to look at the effect of fenfluramine for sudden death. And in animal studies, it appears to be protective. And so this is all very emerging, and I'm not promising or saying anything definitive, so please understand that. But I also wonder about, as we go forward in the treatment of epilepsy, and thinking of which medications might control seizures better, but which medications might reduce the risk of death better. And that's, something that is not even arguably irrelevant. I mean, that's a major issue.
Dr. Stern, we do have another question in regards
Please.
to Fintepla. Does it work for sodium channel epilepsy? My current meds are clobazam and Vimpat. That's from Amanda.
So I don't know. And that's because the studies for Fintepla, which is the brand name for Fenfluramine, are really for Dravet. And that's where we have the best evidence, which is a different condition. I said earlier, and I'll stick by it, that very often medications that work for one can work in other situations. And that's something that's learned over time. But we're still very early on. And I think there may be a slower progression to start thinking about other forms of epilepsy because of the important questions that need to be answered about the heart safety of fenfluramine. I said that the risks in the group in Belgium, the kids looked really good, but then we have the reality of what was seen in a different group of people in the US and, you know, for weight loss. And so part of the approval for this medication includes monitoring the heart with echocardiograms, ultrasounds of the heart. Not painful, still, you know, something that has to be done, and looking for signs of this. In the clinical trials, in the phase 3 trial, 119 participants received Fintepla or fenfluramine, and received it you know, for weeks going on to months, and there was no sign of any problems with the heart in that group of people. And so it's what's true here is true across all medications. You never know until you have a large number of people who've taken it for a long period of time. And as that happens, understanding of safety becomes more clear. And so I think prudence and just good judgment is using it in situations where it really is absolutely necessary because there are no other really good options. And as you do that, you're doing it in a way that's ethical and sound, but you're also learning what the real risk is in terms of expanding it in situations which may not need it as won't need it as much, put it that way. It's hard to compare who needs what, but still, how many options there are and what many medications have failed and what the evidence is for working for one form of epilepsy versus another. It's kind of a long-winded answer to your question. So the third new medication is a medication that we have less data about because it really is newer, but stands out and contradicts a few things I said already during this lecture. So it's Cenobamate, which was approved for focal seizures, and it's in adults, and it can be used by itself or as an adjunct. And its mechanism has similarity to some other medications, but no overlap. A lot of our medications work through the sodium channel. I mentioned that earlier for the problem with Dravet syndrome, but these medications work exclusively toward blocking the channel in a certain way. Cenobamate affects the sodium ion currents on the neuron, the brain cell, in a very different way, affecting a different current. It's almost, I'm trying to think of a good analogy. It's like sometimes you've got these things going on and off, and you got the slow leak elsewhere. It's the slow leak. That leak is deliberate, it's persistent, it's part of what regulates the cell, but it's affecting a different aspect of that ion current. And then GABA is a neurotransmitter that's affected with many different medications, but affected is on and off. And this affecting GABA in maybe an analogous way where it's the slow presence of it. And so mechanism is almost like a foreign accent version of what we know normally, and that it's kind of there, but it's also very different. It's almost like a slang. During the development of Cenobamate, some of the volunteers developed a rash, a very severe rash, type of rash that can be fatal in some situations. And so the medication development was slowed, and then the titration, the beginning of the drug was slowed. And so what we know is that 3 out of about 2,500 people developed this very severe rash. But when the treatment plan was changed after that first 1,000, the next almost 1,500, none of them developed it. But that comes back to the issue of safety. Knowing that none out of 1,500 developed it is not going to be as meaningful as knowing that none out of 10,000 or 50,000 didn't develop it, which is what we need to know now. And Cenobamate's only a few months old. What makes Cenobamate very exciting, and what some editorialists in neurology have called a game changer, in that sense, are the response rates in the trials. I said earlier, you remember from 20 minutes ago, that the trial results for the epilepsy drugs have all been basically the same. That you have response rates about 40%, the placebo rates about 20%. Does that sound familiar? Well, Cenobamate did the trial, same structure, same types of patients, everything else was similar, not the same exact patients, but still, what you would normally do. You can see response rates that are much higher, 60%, thereabout, with placebo rates that are still about the same. So the separation seems greater. But then, well, actually, before getting to that, you have the issue of not just response rates. Here, I'm going to go back and clarify something. When a clinical trial is conducted for epilepsy, the people designing the trial can't expect that medication being tested is going to produce seizure freedom. That's too much to ask. That's what we want, but it may be too much to ask. And if very few people become seizure free, then you may not have success for the study. So what you want to see is that it makes things better, that people have fewer seizures. And so you think about how many patients in the study have their seizures cut in half, 50% response on the medication versus placebo. And that's, shows that there's benefit and allows the medication to be used. But of course, whenever I prescribe a medication, I'm hoping that for seizure freedom, not for cutting in half. But I'll take what I can get, as people will, in difficult situations, but you still want the best, of course. And what happens to Cenobamate, not just the response rates, but the seizure freedom rates were really much higher than we've seen before. And so this is a publication from this year, and this shows how timely this information is, looking across many medications over many years. And the seizure freedom rate and the placebo seizure freedom rate in the study. Now, you might be thinking, well, why would the placebo make somebody seizure free? And it could be that just during that 12-week period, they didn't happen to have a seizure. Maybe they had a bad bunch of seizures over a month or two, and then things got better for a month or two, and you didn't know that when the person enrolled. And so it's just a matter of the natural, frustrating fluctuation in seizures that can occur. But just, looking at the numbers across these medications, you can see that the Cenobamate numbers are that much higher for seizure freedom. Obviously, it does not mean that everyone becomes seizure free, but the question is, why is this standing out? And whether it's the mechanism or not, it's still getting a lot of attention because the trial results differ. And we're at the point now of getting a better understanding of whether this happens in the real world. The real world matters more than a trial, but we end up making our decisions for the real world based upon the trials. They give us a sense of what might work and might not. And so it's a matter of going forward and also being aware of that in the individual investigations, some people develop very serious rashes. And so we need to go slowly and figure out what is going to be the best thing. And I said earlier, sometimes it works initially, maybe because the placebo would work initially. The longer you wait, more of that goes away. And looking at people up to 25 to 30 months, the reduction was still there. And so there's sustained benefit, which is not controlled with the placebo, but still important. And I think I'm going to get to the issue. This is a matter of monitoring later on. This was a large study which showed low risk for rash. So I'm going to finish up in terms of new medications with the matter of acute treatment need. And this is really not a matter of new medications, but new use of old medications, thinking of seizure emergencies. So seizures can occur in clusters. And a cluster is when a person who has many seizures over a short period of time and then no seizures for a longer period of time. And so clusters have been called acute repetitive seizures, flurries, cyclical, serial. There's no really official name for this. And in fact, there's no official definition for it either. In some studies, it's been when a person has 3 or more in 24 hours or 2 or more in 24 hours. It's hard to pin down. But from my experience, the patients who have this know it. And so it doesn't really matter what the statistical threshold is. It's that they know from the pattern of their seizures over time that when they have one seizure, they're very likely to have another one over a short interval, an hour or 8 hours. It just means that that risk goes up. How often it occurs really depends on the definition. And the estimates for how common it is in epilepsy, I laugh because the estimates show that it's between 13 and 76% of people with epilepsy. I mean, that's pretty meaningless in terms of how broad the estimates go. And it goes along with the idea is how close together they are in time. And some of these studies look over a long period of times, which become less relevant because if they define cluster as you're likely to have a second one within a week of the first, you know, is that really a cluster in terms of a meaningful change in treatment? The real relevance is how do you stop seizures? And if a person knows that having one seizure means another one's very likely, then that knowledge is usable. It's usable to try to prevent another seizure. And with that, prevent a risk of an injury that might lead to calling paramedics, EMS, that is, or go to the ER or emergency department, or even progress into a prolonged seizure. And so the question which faces us, which we've never really addressed as clearly, is how to use the fact that clusters occur for some patients as a way to minimize the impact of seizures overall for those patients. And so it comes down to a matter of delivering a rescue treatment. If a person's in the hospital and they have an IV, it's very easy to inject a medication to stop a seizure. Bring it that way can mean having it take effect very quickly, and that's the objective when a person's having seizures that won't stop. That's status epilepticus. But you don't necessarily, when you have a cluster, need a seizure medication to work at that moment. You need to work very soon and then work and continue. Getting a medication into the body, well, it sounds pretty obvious. You just swallow it. But in fact, there's a lot of chemistry involved in this, and I don't mean for these numbers to create fear, but it has to do with how the medication is absorbed. And how something is absorbed also depends on how large is that surface against which it can absorb. Meaning a bigger sponge can soak up more than a small sponge. And ultimately, you need to have a certain quantity of medication in the blood and be absorbed. And so different ways of introducing medication have been studied, where if you inject a medication under the skin, which is subcutaneous, or into the muscle, intramuscular, you've got a very small area for the medication to be absorbed into the tissue. But if a medication is swallowed, there's a larger surface area in the gut. But if you inhale or squirt into the nose, you have a different surface area for absorption. And then you have the question of how do you dissolve medication? So all this really comes back to the issue of the chemistry, dissolving the medication, and how does it get absorbed? And maybe the more practical point of this is that you could take a pill and stick it under the tongue, but that doesn't mean it's getting absorbed. Or you can take a liquid of a medication and squirt it into the nose, but that doesn't mean it gets absorbed. And so for actually squirting a medication into the nose, what you need to do is make sure that the entire amount that gets squirted coats the layer of the nose and doesn't just drip out either the front or go down the back, because that's the same as either being sneezed out or swallowed into the gut. But it has to coat that surface and then get absorbed across that surface. And that problem, it turns out, is more complicated than you would think. And that's really why we're in 2020 now having this conversation, not so long ago. What we have now in the past 11 months are two intranasal nasal rescue medications. One uses diazepam, which is also called Valium, and that's a 1963 medication. And the other is midazolam, which is related to diazepam. That's also called Versed. That's actually commonly used in the ICU in larger doses. And these two preparations allow for delivery of a rescue med into the nose in a way that that medication is actually absorbed across the nose layer. It's called the mucosa, and can provide medication within the bloodstream much more reliably and typically faster than anything in the mouth. And so thinking about what's new in the treatment of epilepsy, having rescue medications at home that are easy to use, a squirt up the nose, not for regular day-to-day therapy, but for rescue therapy, thinking about clusters or prolonged seizures, presumably, is really a game changer. You see the bottom of the chart is alprazolam, this is intrapulmonary, and then phase 3. This is still being developed, and this would be an inhalational medication where it's inhaled into the lungs and much faster than anything else. But of course, it would require making sure it gets inhaled, where something gets squirted into the nostril doesn't require any cooperation.
Dr. Stern, there are a couple
yeah.
questions, if I may.
Yeah,
This is
I may say one thing, if I may, first, because I think it might be what you're asking. The intramuscular for midazolam, it says DOD, FDA pending. And just as an aside, the Army has used intramuscular diazepam and midazolam for decades. And so now the FDA is thinking maybe based on the Army experience, they might be able to approve it because of widespread use among soldiers. But go ahead, please. What was the question?
This is from Thomas, and he says, my son has been refractory for over 30 years and is not a surgery candidate due to a lack of localization. We are trying to decide between Onfi and Xcopri, tonic-clonic, likely frontal lobe. Any thoughts?
You know, my two thoughts are first, you brought up surgery, and the question of surgery is an ongoing shifting question because the means we and other centers, what we use to address the surgical question change because our technology becomes more sophisticated. And so the point is not being a candidate for surgery 5, 10 years ago or more may be different now because of the ability to identify sources in a better way. So that's really a general answer. And the other answer I have, which is also a general answer, thinking about Xcopri or Onfi, the new medication I mentioned, and a medication that's been available in the US now for 10 years, but also a very important medication, is really a tough one to say. And it comes down to all the nuances of a person's own medical history and what medications worked and which ones didn't, which ones caused side effects, which ones didn't, and trying to use all of that information to make the best decisions. So, you know, I can't answer that way because it's not as simple as this one's better than that. It's really a matter of, pardon the cliche, a case-by-case basis. Hope that helps.
And then there was just one more question. She wasn't sure this is part of the talk, but was hoping Dr. Stern could speak to Fycompa, which has a black box label for homicidal suicidal thoughts. How prevalent is this side effect in people? Thanks.
Okay, that's an important question. And I'm going to address the suicidal thoughts first, then move on to homicidal. And so the FDA became concerned about one of the anti-seizure medications causing suicidal thoughts in the early 2000s. It's not public which medication that was, but there was one trial for one medication that came about around that time, where in the study it looked like there was increased thinking about suicide, which is concerning. But when they looked at that data, they didn't show that it was statistically meaningful. They couldn't say that it was more than chance that people on the medication thought about suicide more than the placebo group. And so they made the interesting decision that instead of dropping the matter, they would combine all the trials done over the prior 10 years or so and get a much larger number of patients on medication and on placebo. But of course, these people would be on medication for many different medications, many different reasons. And they found that the anti-seizure medications, the ones they looked at, doubled the risk of thinking about suicide. But it doubled the risk from 0.25% to 0.5%. And so it was such a small increase, they needed to have tens of thousands of people in the combined studies to measure it. And the pushback, as you're probably thinking now, is what's the meaning of this? What's the relevance? Or should we care? I mean, we should care about suicidal thoughts, but increasing from 0.25% to 0.5%, what does that really mean? And the other part is you're looking across many different medications. So what does that mean? And so in fact, that observation has led to two things: some skepticism from the doctors about whether this is meaningful, and the European equivalent for the FDA, it's called the EMA, looked at the same data and decided otherwise. They thought this is not meaningful. So different regulatory body, different decision. But the FDA, because they used the criterion of medications for seizures, deemed that every medication going forward that shows benefit for seizures will automatically get that warning. And so Fycompa has that warning of suicidal thoughts, but so does all of the other modern medications. And the reality is that medications really are quite different from one another. And having suicidal thoughts is not the same thing as suicide. And that's been shown. There's no increased risk of suicide. So it has to be seen as being maybe a marker of a mood change, and nothing more than that. And so that maybe addresses the suicidal part of it. The homicidal thought is also, a difficult thing to understand is how it came to that point. During the studies of Fycompa, there were a handful, I think it was 6 people who at some point expressed anger at other people. And how they expressed this differed, but it wasn't clearly homicidal thinking. And some of the time it was a year and a half after starting the medication. One day they said they felt like hurting someone, but it got written down. And because of the seriousness of such threats, it found its way onto the official prescribing information as homicidal thinking. I think in reality, what is true, I mean, I'm not sure how to interpret, I think it was 6 people saying something over a period of a year and a half, one time, and how often that occurs just in regular life. But Fycompa can cause a mood change, and Keppra can do the same, where people might get more irritable and for Fycompa at higher doses, and it depends on the dose. And so that maybe is more important to know, where if a person doesn't have the feeling of being irritable, then it's a non-issue. And dosing can help make sure that they don't have that side effect. I hope that answers the question. Other questions at this point?
Yes, there's one more. Is Fycompa related to phenobarbital, like a sister drug?
It is not related at all. Different mechanism. Not really at all. And guess what? I just realized that was my last slide.
Good. We have another question.
Yeah, okay. We're all set for questions. I wanted to, I'm looking at the time, thinking, making sure there was time for questions. And so we do have more time for that.
I was just going to say, Dr. Stern, I think we lost your slides. Can you speak to something another participant mentioned? A new FDA warning about lamotrigine, arrhythmia?
Arrhythmia. All right. So that fits into a larger recognition that, what I observe is that the FDA develops greater interest in certain problems for medications, and it becomes, when they see it with one type of medication, it spills over. And so suicidality is an example of that. The concern about suicidal thinking for the anti-seizure meds in the early 2000s seems to maybe follow the increased concern about suicidal thinking on the antidepressants a decade earlier. And so these things are important to look at, but then you become more systematic investigation. There was a recognition decades ago about some of the anti-seizure medications causing heart rhythm problems at high doses, but it never really got a whole lot of attention. With newer medications, the scrutiny for potential effects that way has gone up. And so now it's expected that a new medication is going to be tested for the effect on the heart rhythm. The medications for seizures that fall into the sodium channel class, and that includes lamotrigine, the one that was just mentioned, brand name is Lamictal, but also includes, and I'm going to just throw names out, maybe not be conclusive or incomplete, but just have them: lacosamide, which is Vimpat, dilantin, which is phenytoin, carbamazepine, which is Tegretol, oxcarbazepine. I'm forgetting, I'm sure, a few right now, but all of them have a mechanism on the sodium channel. And they all seem to have some evidence that in certain situations it can affect the heart rhythm. And so we need to be aware of that. And it may be more of an issue for people who already have heart disease. And that's maybe part of the thinking now, which goes back to thinking about medication choice. And what side effects would the person be more vulnerable to, or more of a matter of a problem, and which one's not. So yeah, I'd be surprised if we don't think, I'm expecting us to think more about this and start seeing more evidence for it as it's looked for more often. Which does not to say that it's a bigger problem, it just means we're looking for it more often. And I'll say I've had my entire career just a few situations where an anti-seizure medication caused a heart rhythm problem.
And Dr. Stern, we have another question here from Chris. Hi, Dr. Stern, thank you for your time. Is 600 milligrams per day of Vimpat, which is 200 milligrams in the morning, 400 milligrams nightly, too much?
So two answers to that. It's too much if there are side effects from it, but if there are not side effects from it, it's not too much. And in fact, that dose of 600 total was looked at in the trials for Vimpat and found to be a good dose. But it just happened that when people use Vimpat in combination with certain other medications that have overlapping mechanism, that dose produced dizziness. And so the decision was made to keep things simple, to make the top dose 400 on the label, meaning on the package, despite the fact that many people on 600 did perfectly fine. Making that the top dose of 400 was a way of trying to avoid that. But in reality, for Vimpat and for essentially all of the anti-seizure medications, the dosing on the package are a sort of a framework, and it provides a sense of what was looked at in this study. But an important part of understanding how these studies are done is when a study is planned, a dose has to be picked. And that dose is picked by smart people with good information, but it's still a matter of getting a sense of what might be right without knowing because it's ever been used. And so sometimes the trial gets it right, and that dose turns out to be the right dose. And sometimes the trials end up overshooting or undershooting because they just didn't know, and we end up figuring that out over time. For many seizure medications, getting the right dose means sometimes moving above or below the official dose. But getting back to Vimpat, it just happens that we actually do have data for that dose, and that data supports it being good as long as there's no dizziness.
And one more question here. Is lamotrigine's problem only with patients who already have heart issues and not with patients who don't have heart issues already? Thank you.
So here's a point, a rule in medicine I can say is never say never. And it becomes a matter of what's likely or not likely. And so I think overall, because lamotrigine has now been around, well, I think it was 1994, it came to the United States or thereabout. So 26 years, and heart rhythm problems from it have not been really well reported, meaning not commonly seen. I think the risk is going to be low, even if it's possible. Maybe leave it at that. But if you want to stratify the risk, then I'd say that risk goes up, even if it's low in somebody who has a heart problem.
At this time, we don't have any more questions in the chat, and we have, and I think our time is up. So again, if you do have a last minute question, please type it in right away here. And if not, thank you very much, Dr. Stern, and it was very informative. We really appreciate you being here.
Thank you for the questions, everyone. These are great questions.
I don't see anything else in the chat box, so thank you.
All right.
Oh, wait, one came in. If it's been 13 years since last known seizure, patients on a low dose, 150 milligrams, 2 times daily lamotrigine single medication, how comfortable would you be trying to remove it?
So first, I wouldn't consider 300 total lamotrigine to be a low dose, maybe more of a medium dose. But the point is, if a person's on a very low dose of medication for many years, of course, the comfort goes up about being able to stop the medication. That's not the situation in my scaling of lamotrigine here. But the problem that's being described is, it's a frustrating one because we never know whether the seizure freedom is because of the medication or because of the problem's gone away. And there's no test right now that answers that question, although I'm hoping with the research that's underway that this question may be addressed in the future. To address the problem in the specific situation, it really depends on the following variables. These are what are commonly used in making the decision: is how many seizures occurred over how many years prior to gaining seizure control? Was the EEG abnormal at the time of the seizures, and now has it become normal? Is the MRI normal? And then maybe more important than everything else is how important is it for the person to come off medication? You know, what are the risks of staying on, and what's the burden of being on? And lastly, knowing that coming off medication does increase the risk, questions how much. And so safety restrictions are warranted, and not driving And typically that's for 6 months. That kind of addresses the basics of what goes behind this. I'm sorry I can't answer the particulars.
Well, thank you, Dr. Stern, for spending the extra time with us. Much appreciated, and we'll see you soon.